I guess okay, great. So it looks like we're recording. Do you want to go to the next slide potentially, Annette, and we can go over the agenda? Um, okay, so thanks everyone for joining. Welcome to the Cost Growth Target Technical Advisory Group meeting for February. We have actually a somewhat packed agenda for an hour-long meeting, so I'll try to get to it. This is our agenda. We're going to give a couple of program updates. We have a presentation to talk about reasonableness meetings for the current measurement period of 2022 to 2023, which are going to be happening the next couple of months, and just some sort of advice about how to prepare for that and more information about how that process is going to go. Then we have kind of a tutorial overview for providers who are undergoing validation right now of what to look at and their provider data output for validation. We have a few reflections and lessons learned for the CGT4 workforce data submission process from this year, which was new. And then we'll have wrap up and go over what we're talking about at the next meeting. So I think we can go to the next slide. And we're going to do some program updates. I'm going to hand it over to Sarah for the next couple of slides.
Thanks. Hi, everybody. Happy February. Wanted to make sure that everyone was tracking that we are getting ready to launch a new committee. It's actually two new committees for the Oregon Health Policy Board. As you know, the Cost Growth Target Advisory Committee shut down, stopped meeting after December of last year, and this is the replacement plan for that. So the Oregon Health Policy Board is creating an affordability committee. And related to that, a separate industry advisory committee. So the Affordability Committee will be making recommendations back to the Policy Board, and the Industry Advisory Committee will be providing input to the Affordability Committee, responding to questions, and really making sure that payer, provider perspectives broadly across Oregon are reflected in those policy recommendations. Next slide. The policy board has discussed membership. And so for the affordability committee, membership will be focused on patient advocates, healthcare consumers, healthcare purchasers, and experts in health economics and health policy. The industry advisory committee will be, again, focused broadly. So we have payers, providers, brokers, and a lot of variation within that. So looking for behavioral health, primary care, oral health, looking for large, small, independent medical groups, hospitals, both large systems and rural hospitals, as well as professional associations, tribal health representatives, and traditional healthcare workers. For both committees, members will need to have a demonstrated commitment to affordability, either individual, personal, or as part of the organization that they'd be representing. Next slide. So we are just about to launch recruitment. I really had hoped it would be live for today. It's not. It's still probably a few more days out, but we'll be putting up a new webpage, call for applications, and the application form for both of these committees. That will be up shortly, and we'll be pushing that out to the Cost Growth Target distribution list, as well as the policy board and a number of other channels. The applications will be due in late March or early April, and the policy board will be reviewing applications and appointing members for the committee this spring. We were originally hoping that the committee would be launching, both committees would be launching in May. That may be pushed out a little bit depending on how the recruitment goes, but we are getting very close to launching that recruitment and wanted to make sure that all of you who might be interested knew that was coming very shortly. Any questions about the new committees? Okay, next slide. We also wanted to make sure everyone had a save the date for the 2025 Cost Growth Target public hearing. So as many of you are probably tracking, every year after we publish the annual report, we hold a public hearing. This will be the second year that the public hearing is hosted by the Oregon Health Policy Board, and it's going to be at their June 10th meeting. It will likely be from 9 to noon. That's the typical board meeting time. And the format is still TBD. We're considering a hybrid meeting, so some combination of virtual with an in-person gathering space. So save the date, more to come, and we'll certainly be reaching out and working with many of you about being potential panelists or opportunities to engage in the public hearing as we develop that agenda with the policy board. I think, Margaret, back to you.
We can go to the next slide. So this is just a quick update on the provider cost growth data, so CGT1 validation process. We completed CGT1 validation with vast majority of payers this past fall. We still have a couple of outstanding questions that we're taking care of with 1 or 2 payers. But we were able to roll up all of the data and produce provider data outputs for the 2022 to 2023 cost growth period. This year we have 54 provider organizations identified for participation in the program. All provider organizations at this point should have received their data summary. So if you are a provider organization and you're wondering where your data is, like, let us know, because you should have received it. As of this past Friday, we had validation meetings with 11 organizations, and 8 of those organizations had completed validation or had no sort of outstanding questions from the validation process. Any questions on that update? Okay. Yeah, and we're trying to complete provider organization validation in the next month and a half or so. So I'm going to now pass it back to Sarah. Annette, if you want to move to the next section, and Sarah's going to go over some reasonableness meeting overview for this year.
Thanks. Okay, so hold on, back up, back up, Annette. Okay, just to intro this, we wanted to provide a little bit of a refresher, remind everybody on what the reasonableness process is, when it happens, and what payers and provider organizations can expect. We want to talk about some changes that OHA is making this year. We really appreciate the conversation that we had with TAG members as well as with a number of you individually about reflections on the reasonableness process for 2021-2022 and what we learned. And so we are incorporating that and making some changes that we want to share with you today. And then finally today, we also want to share some new guidance that we have that we'll be releasing publicly later this afternoon for how payers and provider organizations might want to prepare for reasonableness meetings. This is something that a number of you indicated would be helpful. And so we have some optional guidance that might help you prioritize or prepare for reasonableness conversations with OHA for this data cycle. Okay, next slide. So reminder, we have a process and criteria for determining whether or not cost growth above the target is for an acceptable reason. If payers and provider organizations are found to have an acceptable reason for cost growth, no accountability measures apply. This was all part of the rulemaking that we completed last summer, and we've gone through our first cycle of this, which just wrapped up in January. So we're ready to move on to the next cycle. And you can see the list of those acceptable reasons on the slide. Next slide. We are ready to start the reasonableness process for the 2022-2023 measurement period. So just to ground everybody in where we are in the cycle, this is year 3, cost growth target year 3. We're looking at cost growth between 2022 and 2023. This was the data that payers submitted in 2024, last September, and that we finished, or just are finishing validating with the payers and are in the process of validating with providers. We'll be publishing the cost growth annual report for this measurement period in late May or early June, time to that public hearing I mentioned. In the report, payers and provider organizations will be publicly identified as they have been for the last several years. What is new with this cycle, the 2022-2023 measurement period, this is the first year in which a payer or a provider organization could be subject to a performance improvement plan if at the conclusion of the reasonableness process, they are found to not have had an acceptable reason for cost growth. So clarifying that this is the first year. So we talked about last year being sort of the practice run, the dry run, understanding how it all works, going through the process, but PIPs did not apply. This year is the first year that PIPs could apply. Next slide. So a couple of key points here in where this whole process fits and why it's happening now. So reasonableness, the reasonableness process, the reasonableness meetings and determinations all happen after the data validation is complete. We don't want to be discussing whether or not cost growth was for an acceptable reason if we don't have, if there are outstanding concerns about the data itself. We have completed validation with almost all of the payers and are starting with the providers, as Margaret shared. So we're planning to start the reasonableness conversations on a rolling basis. We're planning to start with the payers that have completed validation. So you'll be hearing from OHA shortly, and I'll talk more about that in a minute. Starting that process, scheduling those meetings. As provider organizations finish validation, we will be starting to reach out to provider organizations to schedule reasonableness meetings on a rolling basis. So we were waiting for a couple of things. I know some payers, you completed validation several months ago, and we're probably waiting for this. So now that we've published the report in January and closed out last cycle, we're ready to move to this cycle. We will reach out, notify payers and providers of cost growth and the next steps. That will include whether or not a meeting is required. We'll schedule a meeting. That may be one meeting, it may be several, and that will be to discuss potential reasons for cost growth. That there'll be some back and forth. There may be email questions, and then OHA will issue the decision, and that's the formal order of proposed determination of reasonableness. Next slide. So this is one of the changes that we're making based on your feedback. So we are going to send notification to all payers and provider organizations this year about reasonableness. Last year, last data cycle, we did not. We only sent to those entities that were over the cost growth target and needed to have a meeting. So this year, we have 4 potential outcomes that the notification will be indicating. So the first, on the right-hand side of the screen here, the payer or the provider met the cost growth target and a reasonableness meeting is not needed. So this is documentation. You'll have this is the cost growth performance. It will be published in the May report. No need to meet, nothing else to happen. End of the line. Second outcome is cost growth is indeterminate. And again, no reasonableness meeting is needed. Third is exceeded the cost growth target and OHA has already identified an acceptable reason for cost growth and a reasonableness meeting is not needed. So this outcome is essentially a predetermination that cost growth is reasonable. These notification letters are not going to be the formal official determination, but for payers or providers in this category, this will be because OHA has done analysis. We already know for example, OHA raised the Medicaid rates, and we can see exactly how that influenced cost growth. And for some Medicaid providers and payers, that may be sufficient, and no reasonableness meeting is needed to really get beyond that. Of course, if any payers or providers want to have a meeting, that is going to be an option, and we'll talk about that in the letters as well. And then finally, the fourth outcome is payers, provider organizations who exceeded the cost growth target and a reasonableness meeting is needed. So the notification will clearly provide next steps for how to schedule and respond to that. I think there are a couple questions in the chat. Margaret, is there anything we should pause for?
No, we're just clarifying that FQHCs and pediatric organizations are exempt from financial penalties, but I'm looking in the OARs for
the exact citation. Okay,
yeah.
Awesome, thank you. Okay, then I'll keep going. Next slide. So we are going to be providing some guidance about the reasonableness meetings. And again, this is suggested. This is just if it helps you prepare. This is not a binding requirement from OHA. So we've had some questions about who should participate in reasonableness meetings. Wanted to be really clear that it's up to each entity about who should participate, and that there's a lot of flexibility. So if a payer or provider organization is over the target and needs to have a reasonableness meeting for multiple markets, maybe for Medicare Advantage and commercial, depending on how the organization is structured, how it's staffed, it may make more sense to do those meetings combined because it's all the same people that would be answering questions or looking at the data, or they may be separate. They may be separate divisions. There may be separate expertise. OHA is open to that and will defer to the entities on how they want to schedule those meetings. Same if we have payers and providers that would like to hold their meetings together. So the integrated delivery systems that have both health plan and provider side may want to have those conversations together or separately. We will follow your lead on that. Also wanted to highlight here that we do not expect that the participants in the reasonableness meeting are necessarily the same as the folks that participated in the validation meetings. They might be, especially for smaller organizations or organizations where there's really a core team that is focusing on the cost growth target program and all of this work, but it may also not be. There may be other folks that organizations want to pull in that could speak to key events that happened during the 2022-2023 measurement period. That may be contracting folks, maybe others. And so we have some suggestions around who might make the most sense to be involved. Next slide. So I mentioned a couple times that we have new guidance. This will be published this afternoon. We'll push it out as part of the TAG meeting materials. This is a brief guidance document that provides some suggestions for how payers and providers can prepare for these meetings and what payers and providers can do in advance. So it's pointing out some key things in the data output summaries, some key questions that payers and providers might want to ask themselves internally, but wanted to just be really clear that OHA is not expecting payers and providers to do a comprehensive analysis and come in with all the justification prepared and be ready for that at the very first meeting. Just like last year, the first meeting may be more exploratory, and then if there are any requests for justification, follow-up analysis, or documentation, that would come after. We're just hoping that this guidance provides a little more structure for folks that are maybe uncertain, or especially for organizations that did not participate in the reasonableness meetings last year, but will be this year. Next slide. So just to highlight what's in this document, here are some examples of suggestions for payers. So where it's broken out into what you could look at, what you could review, documents, files, contextual information, what kinds of internal data you might want to explore, and then potential questions or focus areas. So this is just meant to help identify key cost growth drivers, key reasons, and key policy changes. This is not a requirement that every entity be ready to answer every single question in this document at those meetings. This is more just, these are the kinds of things that OHA will likely be asking about as it's relevant. A lot of this is a more narrowed or a refined summary or synthesis of what is in the CGT-7 guidance document. So that CGT-7 document has a really long list of potential questions that OHA might ask. We created that document before we went through the first cycle. And so now that we've gone through the first cycle of meetings, we were able to narrow it down a little bit onto this is really the key points of conversation. Next slide. And then similarly, suggestions for provider organizations. So what to review, potential questions, and ideas. So again, acknowledging that payers and providers have access to different data. There may be some conversations that need to happen. We're happy to help facilitate those between payers and providers as needed. And acknowledging that there are potential questions that providers might not have an answer to, and we might want to talk more about how we would be able to explore that, whether that's an analysis OHA can do, whether that's data that could be requested from a payer or something else. And as we've talked about before with the tag, the data output for providers this year does provide more detail, more granular detail by payer, so that you might know which payers you might want to engage with or might want to request data with. Data from, sorry, I can't talk. Okay, and then last slide in this section. Just wanted to restate that OHA does not currently have a required format for how payers and provider organizations document or provide their justification of cost growth reasonableness. There's one exception, I'll come back to that. We saw a lot of different things last year. We had emails, we had spreadsheets, we had PowerPoints, we had memos that were written. All of those are okay. Just wanted to be really clear that we don't have a requirement. That said, OHA can provide some suggested templates for some topics. So we know length of stay was a big reason for a number of payers and providers last year. And we have a template for how that could be documented and if that justification could be provided. So these are the kinds of things we can talk about in the reasonableness meetings. The one exception if a provider organization is pursuing frontline workforce costs as an acceptable reason for cost growth, OHA will require the complete CGT4 data file to be submitted. That is the documentation requirement there. So just for context, CGT4 requirement was just to provide the cover page, really just the summary data. But for a determination of reasonableness around frontline workforce costs, OHA will ask for the detailed CGT4 data template. Okay, I just talked to you a lot. Any questions, clarification? Looks like we've shared the link to the document in the chat. Thanks, Margaret. And clarifying that those notification letters, we are hoping to start sending them out to payers this afternoon. So you will start hearing from us, if not today, then by the end of the week, for sure. Questions, comments? Okay, I think we're all set with this section then. Thank you.
Thanks. So we can go to the next slide and yeah, so next section, this is an overview of interpreting provider data output for validation. Just to give you a little bit of background as to why we've included this today. We have started provider data validation the last month or so. And as we've been sending out your data outputs, we've received a couple of questions that are sort of frequently asked. How do I look at this data? How do I compare it to what information I might have internally to validate it? So we just wanted to give you some pointers. As Sarah mentioned earlier, we also were providing a new supplemental data output to everyone this year. So that might be something that you haven't seen before and that you might not completely understand how to look at. So we wanted to give some pointers. Next slide, please. So these are the contents of the two main data output documents that we're sending to all provider organizations. On the left is the contents of the main data output. That's going to be the document that's labeled data summary. It has a cover page on it on the front with your cost growth and a sort of a picture showing whether you're over the target or not based on the initial data that we have. The tables in that are going to be pretty similar to what we've shared with you in previous years. We have summaries of your member months broken out by line of business and then line of business and payer. We have an overall summary of your total medical expenses per member per month in the period by line of business. We have the breakouts by service category and then a list of tax ID numbers as well that we have for your organization. Section 4 in that document is medical pharmacy by service category. That is a new section that wasn't provided to you in previous years. We had the payers start submitting data this year on medical pharmacy costs and from their claims data. So that's going to be things like claims paid for vaccinations or chemotherapy drugs that would have been administered in a physician's office. We know that there are a number of high-cost drugs that are administered in the physician's office that might be driving costs. And so we wanted to break that out to be able to see if it could be a major cost growth driver in a given service category. So when you're looking at the medical pharmacy output, basically, it's going to be broken out by the same claims categories, service categories that the wider service category breakout is. The medical pharmacy PMPMs are a subset of what is in each of those wider service categories. So essentially, if you look at the medical pharmacy PMPM and see that it is a large percentage of the overall PMPM in that service category, that might clue you into medical pharmacy being a cost driver in that category. So that's the medical pharmacy output. It may be more or less relevant for different provider organizations who have costs in that area or maybe don't. On the right, we have the table of contents for the supplemental data output. And without going into too much detail on what's in that, essentially it is further breakouts of your service category and overall spending broken out by major payer in each of your accountable lines of business. So any of the lines of business where you are accountable to the cost growth target, we took the main top payers who were contributing the most member months to your data output, and then broke out their data by attribution tier line of business in that supplemental output. Does anyone have any initial questions on what is in the two different data outputs that we're sending to you? I'm going to take that as a no. So can we go to the next slide? This is just a quick summary based on questions that we've got from different provider organizations of what CGT provider data includes and what it does not include. Overall, writ large, CGT data includes total claims and non-claim spending for provider organizations attributed primary population at a summary level. So anything that the payer data submitter sent to you as a payment for a claim or a non-claim, so prospective payment, for example, like a capitation payment or performance incentives, those payments are going to be showing up in your file. It also is going to potentially and most likely include some costs that were actually made by a payer to an organization that is not you. That's because of our primary care attribution, primary care total cost of care model. So we have your list of attributed primary care patients that you are providing care to. For example, if you're a smaller organization that doesn't provide hospital services, if they go to the hospital, we're going to be including their hospital claims data and costs in your output because it's part of their total cost of care. In terms of what we don't have in our data and what's not included, there are not provider organization sort of overall operational or administrative expenses included in these data. We do not, unfortunately, have price and utilization data. We have total medical expenses per member per month costs. So member months and total expenses, but not how much of that is affected by increases or changes in price versus utilization. That is something that we might look at or try to get more detailed data on during a reasonableness conversation, but it's not included in the initial data output that we have. We also do not have or receive identifiable patient attribution lists from payers. We receive summary data, so not the attribution lists. We could potentially facilitate an exchange between a payer and a provider organization that included transfer of patient attribution, like patient details from the payer to the provider securely if we had a major data validation question that we wanted to look into. I don't believe that we've done that before at this point, but it could be a possibility if there's something that we really needed to look into. Finally, we don't have data on patient health status. And sort of the initial first year that we collected data from payers, we did ask them to give us risk score information. However, we were not able to sort of trickle this data down to the provider level because the different tools that payers use for risk scores kind of don't necessarily speak to each other. So we weren't able to roll that up down at the provider level. So instead of having patient health status information in our data, we have a demographic score, which adjusts your costs for changes in the sex or age of your population over time. Does anyone have any questions on this slide? Okay, next slide. Okay, I just So the next couple slides are a couple of things that you might want to look at, things that you could potentially check against an internal data source that you might have available to you, sort of going through each of the sections of our data output. I think the most obvious check that you might be able to make when comparing the CGT data to your data is to look at the size of the patient population that you've been attributed, both overall and by a number of different breakouts. So we have data that is collecting member months, but so not exactly the same thing as attributed patient lives, but you can kind of get a basic idea of what the minimum, patient population size that you're looking at in your CGT data is by dividing the number of member months by 12. There might be patients in there who only had a partial year of coverage. So in all likelihood, your patient population is going to be a bit larger than the member months divided by 12 calculation, but that's sort of a basic rule that you could use to look at our data and compare it to yours and see if there are major discrepancies. Let's see. Yeah, and you can kind of look at changes from year to year. Does the percent of patients with different types of insurance kind of ring true as to what you have from your business? Yes, okay, I have a question from Deborah. We have significant differences in member months data, especially for the commercial population. If those are identified, what does OHA do to help resolve the differences?
Margaret, I can take that.
Okay.
So there are a number of things that OHA can help do. I think one of the first is there are often just some discrepancies where a provider organization in particular is expecting something and is maybe not 100% clear what's in the data and what isn't. So for example, Medicare fee-for-service is not there. And so if you're looking at the Medicare numbers and that's a disconnect, that's an easy answer. I think another really common thing we see, especially in commercial, is where there are certain payers that attribute a lot of lives to their own organization. So, for example, most members with Kaiser coverage are attributed to a Kaiser practice. That does not mean that a different provider organization does not see patients with Kaiser coverage. They might still see them. That's just not assigned as their medical home, and so therefore not reflected in the attributed cost growth target data. So there are some, I don't want to say easy answers, but there are definitely some known disconnects that we've seen repeatedly each year. And so it might be that that's what's going on. If there are really more specific issues where, for example, let's say the supplemental data is saying that a specific payer is attributing lots of patients to a practice, and the supplemental data tables show that it's all through a contract, but the provider organization says, I don't have a contract with that payer. That's something that OHA would want to take back, and we would help facilitate a conversation with that payer to understand what had happened in the underlying attributed data. That might be a three-way conversation between all the parties to figure out what's going on. But again, we're hoping that the supplemental data tables this year will provide a little bit more insight into that. And this is something that we're happy to talk about with each individual organization as part of the validation meetings. And Daniel's also asking about self-insured groups. And I think at a high level, the answer, Margaret, like please add on to this, but at a high level answer, we do have self-insured data as part of the commercial population. It's not necessarily every individual self-insured employer, but for the large payers that also have fully insured and self-insured, we have many of those lives.
I think it's a mix and it might depend on the payer. So, there have been some payers in the last year of attribution where we went back and had some conversations, and it turned out that, what was missing was in part their part of their self-insured products. And I don't think we are not able to require them to submit that data. So we kind of are dependent on what they end up submitting from what they have. Sarah, correct me if I'm wrong.
And I think, again, the answer here is the same, where there might be questions for a specific payer. And as always, OHA would help try to facilitate that. Last year, we had a number of data requests that came out of provider organization validation conversations that went back to the payers to relook at the data, to provide supplemental data, to help identify patient or member lists. And so there was quite a bit of back and forth that might happen here.
Another thing on the commercial side that we are noticing a couple of times this year is that some payers have a lot more partial claims. So we have them split up the commercial line of business by full claims and partial claims includes patients for whom their insurance might have like large carve outs, for example, people who don't have pharmacy coverage as a part of their plan. So in a couple of cases, the missing commercial months that a provider was asking about, we went back and looked at the full versus partial and saw that there was a large number of partial claims for a given payer that were not making it into sort of the overall cost growth for the commercial line of business. And so I think we're still kind of working on that, but our approach is going to be, to take a look if it is really a large partial claims population to kind of take a look at the cost growth in that population and compare it to the others to see if that's like having a large influence potentially on the overall cost growth in the commercial full claims category. So yeah, I was going to mention that anyways. And since Sarah was going over a few other things that you might see, like no CMS data, I thought I would just mention that. And I think we can move to the next slide, actually, which is fairly relevant to this conversation. Payer mix. Oh, sorry, go back one. Yeah, payer mix. Yeah, so this is basically very similar to the last one, looking at your patient population size and the number of patients who are attributed, a number of member months that are attributed by different payers can kind of clue you into whether there's data that's missing. That's, something we want to go back and have a more detailed conversation with the data submitter about. Yeah, so fairly similar checks, just sort of ground truthing the patient population by payer. And next slide, please.
Hey, Margaret, we have a
Yeah.
question in the chat that's more technical, so I'd like to maybe have you and Yishan take that one. Does the paid amount exclude contract withholds or sequestration? And Janet, I'm not entirely sure if you're asking about that from the provider side. Do you mean like an incentive payment that's negotiated between the payer and the provider and a withhold? Or I guess we might need more specifics on what you're asking about, how that shows up before we can answer.
Yeah, I'm going to say the same thing as Sarah because I don't have an initial, I think I would need a little bit more detail on the mechanics behind that question, unless Yushan has ideas, which she can pipe up if she wants in the chat, I suppose. But why don't we have, we can take a look at that after the call potentially and send out any updated information to everyone. Okay. It's included and allowed amount. Contract with, when you say contract withholds or sequestration, I guess yeah, is not paid.
Yeah, I think we might want to take this question offline. Sorry, Janet. I don't
Yeah.
want to accidentally give you the wrong information. Can we follow up
Yeah.
with you separately?
Yeah. Yeah, I'll send a follow-up message afterwards. Okay. Yeah, that being said, just moving on to the third part of the data output, looking at service category growth. So this is more detailed data, almost the most detailed level of data that we're going to be giving you in your data outputs is growth in PMPM by claims category and non-claims category. And since we don't have access to the actual claims, we might not be able to look into things like price versus utilization without doing further research essentially. But there are a few things that you can kind of ground truth by looking at these data. Hospital, for example, looking at claims categories, if you know of any patients that had large hospital costs or might have had chemotherapy in a year two of your cost growth period, you might be able to sort of match an increase in PMPM to that. There's also been cases where we've had provider organizations who are able to look at an increase in PMPM in a given category and kind of match that to where they were expanding services in a given year. So if you brought on a lot more behavioral health practitioners, and that increased the amount of behavioral health that was being provided to your patient population, that could increase your PMPM and kind of align with what was going on during the period. Non-claims, if you know of, obviously, I think non-claims tend to be a little bit more specific to your actual organization than the claims categories necessarily are, depending on your organization size. So you might be able to look at the prospective payments and performance incentive categories and know that maybe you received extra performance incentives or capitation payments in a given year and sort of match that to what you're seeing. So, if you go through the service category data and you're sort of like, I don't understand where this change is coming from, and it's like kind of counter to what I would have expected, that could clue us into something that we need to go back to the payer and ask some more questions about. Next slide, please. Okay, so the last page on your data output is a page with a list of tax ID numbers. Just to clarify a little bit what we use tax ID numbers for in the program, it's essentially given to us by the payers so that we're able to roll up your costs across different payer data submissions. So we receive the TINs because it's going to be a constant number from payer to payer. Even if the provider name that they have and that they've broken out the costs by might be slightly different from file to file. So in the right, you can see two different payers submitted data for fake organization. One called it fake organization, the other called it fake org. It might be hard for us to reconcile and put together all of that data if we didn't have kind of a common key. So that's what we're using the TINs for. It's a little bit different from what the claims data that we're receiving might have been billed under. The claims, essentially, we're having them attribute costs to you as a provider organization and attribute patients rather. Then they're going to have a patient list. And they're going to use the patient lists, the patient names or identifiers to go and pull all of the claims that they have for those patients. The claims that they pull might have, some claims with your TINs because, obviously the patient population is going to be getting primary care from you, but it might also have claims that have TINs from other organizations in it if they're going to a different hospital, for example. In some cases, having a TIN in your data that you don't recognize is definitely something that, having a TIN that you don't recognize is definitely something that we want to look at and potentially remove. We do have some cases where there's been another provider organization that has a similar name. And so somehow their TIN ended up and their data ended up sort of mixed in with yours. And so we have been able to remove that data and those attributed patients from the file. In other cases, sometimes we've had cases where there's maybe a TIN that you used to use a few years prior, or a TIN from an entity that you acquired, that you bought at some point. In those cases, often what we see when we actually go back to look at what TIN costs for that population we're actually being billed under, it is oftentimes the new correct TIN that the costs are being billed under, but the TIN itself is just mixed in there from the payer data because they're attributing potentially based on a utilization algorithm where there were claims billed under that TIN, 2 years prior or something like that. So there are reasons that having a TIN mixed in that is not yours or is outdated could be an issue. And then there are cases where it might actually be costs that should be attributed to you based on how the data are being structured. Does anyone have any questions on that? Essentially, look at the TIN list. If there's anything weird, let us know, and then we'll look into it in more detail. Next slide, please. Um, okay, demographic scores. This is not something that you're probably going to look at and understand what the demographic score means right off the bat. It might not be a major source of being able to validate your data either, but we just wanted to give a couple quick pointers on like what even is a demographic score? What is that like number that I'm looking at in my data output? And you know, what could it indicate if it's changing? So as I mentioned earlier, since we weren't able to risk adjust the data that we were receiving um, from payers down to the provider level, we came up with the demographic score, which is going to adjust your costs based on the age and sex mix of your population from year to year. We sort of internally at OHA and our team have identified that if there's a change of around 1% or more in a demographic score from year to year, that could indicate like sort of a meaningful change in the patient population's age and sex mix. The absolute value of the demographic score, you know, it is going to depend on what line of business you're looking at. And there are demographic score tables. There's a couple of them here that we're showing on the right for Medicaid, and then the duals, Medicare and duals populations that shows sort of an absolute number means, you know, corresponds to what likely category in that line of business in terms of sex and age. Just in general, the lower the demographic score, the lower the cost of providing care to an individual based on average costs for their age and sex. Um, so if you see a higher demographic score, that means maybe that like your patient population changed towards a demographic from year to year that has higher costs. So that's kind of the overview of demographic scores. Does anyone have any questions? Okay. And if you have any questions about it when you're looking at it in your data, of course, feel free to reach out to us with questions at our email. Next slide. Okay, so this is the last little bit of information that we wanted to share. This is just a screenshot of the supplemental data output that we're providing this year. We recommend using this largely as kind of a second check if you identify something that looks weird in your sort of overall data output. And you want to know, is that weirdness specific to a given payer? You might be able to find out the answer to that question by looking at the supplemental data output. This is breaking out the member months and costs by payer and attribution level, which is pretty much the most detailed level that we have. So yeah, if you identify something strange in the overall data output and you're wondering which payer's data it might have come from, or if it's happening across all payers who submitted data for your provider organization, we suggest going and looking at this supplemental output for a little bit more detail, and that might help formulate some more questions to ask the payer data submitters as a follow-up. Any questions on supplemental data output?
I
Okay.
just want to, sorry, Margaret, I'm going to
Yeah.
jump in. I just want to also add here that these are questions and ways to check the provider data output that are helpful for the validation meetings. Some of these may also provide really helpful information to take into reasonableness meetings as well, especially the service category checks and anything related to contract changes. So in the guidance that I talked about earlier and some of what we're sending out, some of these might be the same answer, it might be the same context that we would want to have as both a validation conversation, and that might also then carry on into the reasonableness conversation later. I also would love to pivot real quick. There is a follow-up question in the chat that I want to take, if that's okay. Blaine
From Blaine, yeah.
Yeah, question about the written notification for identified provider organizations. So this OAR, Oregon Administrative Rule 28, is about the provider data reporting requirements, which means the CGT4. This is about the frontline workforce. And that written notification is, we have been sending that over email. There's a PDF, there's a letter that gets posted online, but we push that out over email. And that's the attributed patients and the providers that are required to submit the CGT4 data file. It's not about meeting the target, not meeting the target. Does that help, Blaine?
Yes, thanks, Sarah.
Great. Yeah, y'all, this program is getting more complex and we have more moving parts now that providers are submitting data as well. So appreciate you bearing with us. I think, Margaret, we're running tight on time. Do we want to do a really quick lightning round on the CGT4?
Yeah, I don't think those slides are going to take too long. It doesn't seem like they're, aside from the question from Janet that we can follow up on, I don't think there were other major questions on this. But of course, if you think of something, feel free to message us afterwards. Sorry, I'm seeing a question in the chat. Some of us have value-based care metrics in our contracts, and percentage of the payment is at risk to meet these metrics. Is categorized as managed care withhold and is included in the allowed, but we don't always get that money if we do not meet the metrics. The payer keeps that money.
Yeah, so I think this is related to the previous comments and questions from Janet and Travis. So I think I want to clarify that when the payers submit the CGT1 data, it is all based on allowed amount. There's an exception for dual eligibles, Medicaid, Medicare dual eligibles, where we're collecting paid amounts because of some technical reasons. This is all in our data submission manual, but all of the underlying CGT1 data that we're talking about is based on allowed amounts. So understand that from a provider perspective, you may not receive all of those dollars for a variety of reasons. I think this is not something that we're able to address in validation. I think this is something that we would be talking about in reasonableness conversations where you're saying because of a managed care withhold, our payments changed, or this is a disconnect, and this is why it looks like we're over, but we're not really over the target. So I want to acknowledge that allowed and paid amounts do not always line up, and the data that we're measuring on for this program, CGT1 data, is allowed amounts with the exception of dual eligibles. Cool. Okay, Shannon, that helped. Sorry, Margaret, keep going.
Okay, yeah, lightning round on CGT4 data validation. So can we go to the next slide, please? And then what after that? So as of this month, we had received and validated all of your workforce data submissions. So thanks for all of your work on that. Next slide, please. The quick summary is that we received a CGT4 from 25 organizations this year. 5 of you provided the detailed data that breaks out workforce costs by different occupation type. So thank you for that. Out of the 25 organizations, we had 10 who had their files validated with no questions asked, no irregularities that we identified. Then we had around 8 entities that had clarification questions, and then 7 who had a resubmission for one reason or another. Next slide, please. Common reasons for resubmission. We had a few folks who missed some of the specifications and submitted fiscal year data instead of calendar year, or submitted data for the wrong period. We had a couple of cases where data on the cover page didn't match the totals in the detail tabs, and as noted on the right, that was in a couple of cases as a result of some issues that we had with the templates. So we're fixing that in next year's template that we'll release. We had someone who submitted totals rounded to the nearest $1,000, which is not ideal from our perspective. And then a couple of cases where there were missing pieces of missing data in various forms that were supposed to be provided. Next slide, please. So we're working on kind of updating and clarifying the template and the guidance to hopefully prevent some of these issues in the past. Overall, it wasn't a super difficult validation process, but there's definitely improvements that can be made in terms of how the template is structured and the guidance that we're giving to you all. So we have some improvements to the data submission template. We're going to correct the error in the subpages detail tabs that led to some of those incorrect and not matching detail versus summary page disconnects. We are adding formulas actually to the cover page to pull in data from the subpages, which if you are not filling out the subpages, you'll be able to just like delete those formulas and fill in your summary data over it. We're going to replace current year and previous year with year 1 and year 2, just because the current year and previous year, I think, was potentially a little confusing to some folks. We're adding comments on the totals on the different lines, sort of defining what should go in each category, just so you have that as more easy access. And then we're also going to put in a validation tab that you can use to just do some really basic checks to make sure that the data that you're submitting like makes logical sense in terms of things being, some figures being subsets of other figures that are supposed to be, that not all people had that in their submission this year. And then for the folks who filled out the detailed subpages, there's going to be some summary statistics that they can just sort of look at to kind of ground truth. So we're hoping the validation tab might, plus those sort of clarifications in the template, will help improve and make the process a little bit easier and clearer for everyone and shorten the validation back and forth that we have to have. Next slide, please. And so we have 3 minutes left, 2 minutes left now. Does anyone have any reflections that they would like to share on the CGT4 data submission that might be helpful to us in updating the documents for the coming year? I'm hearing no, and that's completely fine. We are going to, I think, before the next tag meeting, be finalizing our updates, or almost finalizing our updates to the template. And so we'll share the actual template out for you to take a look at and provide any additional reactions to. And we'll discuss that a little bit, or have some space to discuss it at the next tag as well. Next slide. Next meeting is going to be March 26th, so a month from now. Next slide, please. And the anticipated agenda is that we're going to, as I just mentioned, review a draft data template for the CGT4 that we'll have you fill out for the upcoming period, which will be 2023 to 2024 data. And then we're also going to be formulating a list of some changes that we are going to make to the CGT1 data submission manual for the coming year. We're hoping to keep those changes fairly basic this year and just kind of more focused on making corrections or clarifications, as opposed to giving you a whole new data submission aspect to take on, like we did with medical pharmacy last year. But we'll be sharing that list of proposed updates at the next meeting, and also hopefully provide some space to check in on the reasonableness process. So I think that's everything we got for you today. And it's 11 o'clock, so feel free to go about your days and send us any follow-up questions that you might have. I will send out an email as well to point you to the materials from the meeting afterwards. Thanks.
Thanks, everybody.